Hello everyone, so I hope all of you are doing fine. I'm Shabana this side, your friend and colleague, and I'll be discussing about patient safety points in some other modules like early pregnancy, labor and delivery, postpartum, and some gynae and urogynae modules. So in the early pregnancy, we know that there are some topics which are very important, like ectopic pregnancy, molar pregnancy, and pregnancy of unknown location. So we need to know how to interpret the results of serum beta HCG, ultrasound findings. Also, we need to discuss about the screening tests for Down syndrome. So that is the combined test, and if screening test is a high risk one, we have to discuss about invasive prenatal diagnostic tests like CVS and amniocentesis with the patient. And when we are discussing these tests, then we have to say that these tests will be done by the experts, the baby doctors, that is the fetal medicine doctors. And there are some risk, and like the important one is the risk of miscarriage, which can occur in about 0.5% or less. That is, it can occur in about 5 in 1,000 procedures. Okay. And also we have to discuss with the patient with NIPT, that is the non-invasive prenatal test, and tell her that it is not a diagnostic test, it is only a screening test. So if the screening tests are high risk, we have to offer the diagnostic test, because these diagnostic tests will help to give us a yes or no answer whether the baby is having Down syndrome or not. Then another important station is the one where the patient has history of recurrent miscarriage, and she is in her early pregnancy. So of course we need to offer her aspirin and low molecular weight heparin if the recurrent miscarriage is because of antiphospholipid syndrome. Any medication we will prescribe after ruling out allergies and any contraindication. Coming to labor and delivery, again, if we need to examine the patient, it has to be always with her permission, in the presence of chaperone. And here regarding the history, it has to be very focused and targeted. We will not be asking about the family history and social history, like no need to ask about smoking, alcohol or recreational drugs, particularly if the patient is in labor. You have to make a safe plan which needs to be mutually agreed between you and patient. Like if the patient had previous cesarean section and she wants home birth, and then we have to discuss with her about the pros and cons of options available for her. Like we need to discuss about the pros and cons of home delivery versus hospital delivery. But we are not going to agree for home birth because of increased risk, like risk of scar rupture is there, which can occur in about 1 in 200 cases. She will need continuous electronic fetal monitoring with the help of CTG. If scar rupture occurs, if there is any fetal distress, then she will need emergency cesarean section, and operation theater has to be nearby, because because if there is any delay, then it can be very, very risky for her and her baby. So we need to tell her that it is highly suggested to deliver in hospital and in consultant-led unit in women who had previous cesarean section, because this is the safest option for them. Yeah, they can't even deliver in midwifery-led unit. It has to be the consultant-led unit. Then coming to labor ward prioritization, we know that these are a must station in the exam. We have to triage the patients as urgent, semi-urgent, non-urgent, depending upon the urgency of situation. Then again, we have to see whether we need to write the incident reports, for example, in cases of 3rd and 4th degree perineal tear. Then another risk management issue is, and the safety issue is calling for help in cases of maternal collapse, acute inversion of uterus, and in PPH. Coming to the postpartum module, just remember a few points with the help of a mnemonic: A, B, C, D, E. A is the assessment of patient and assessment of observations, analgesics, antibiotics if needed, and anticoagulants. B is breastfeeding, have to prescribe safe medication in breastfeeding patients. C is the contraception. D is documentation, DVT prophylaxis, debriefing patient in cases of PPH or shoulder dystocia. E you can remember as expert reference, that is follow-up. In cases of diabetes, follow-up will be with the diabetologist. In patients with renal condition, follow-up will be with the nephrologist. Okay. So even after the patient's delivery, if she had any history of medical condition, the MDT management is still important. Then coming to the gynae module, here we need to know about the referrals, like in cases of complex ovarian cyst, where the RMI, that is risk of malignancy index, is more than 250, we will be offering the patient CT, refer to the radiologist. Second thing is referring the patient to the MDT. There has to be an MDT meeting involving the consultant oncologist, counselors, radiologists, specialist nurses, okay? And the safe plan will be there for the patient's further management. And then remember the stepwise management. Simplest example is HMB. In heavy menstrual bleeding, the first line treatment is Mirena coil if it's not contraindicated. Second line treatment is other medical management, like of course if hemoglobin is low, she will be given Hematinics. The non-hormonal medical treatments, tranexamic acid or mefenamic acid. Then hormonal medical treatments, these are the contraceptions, right? Either the pills, injections, or even the progesterone. After that, discuss with her about endometrial ablation if the family is complete. Then, as a last resort, surgery, hysterectomy, okay? Then also, whenever we are prescribing medication, we have to know about the risk factors. Like in post-menopausal patients, if the BMI is more than 30, we cannot prescribe her the tablet forms of HRT because it increases the risk of thrombosis. Offer her HRT patch or gel, another patient safety point. Now coming to the fertility module, here there is role of preconception counseling also. We need to offer the folic acid before conception. Rubella immune status needs to be checked. Confidentiality has to be maintained whenever we are discussing the reports of the partners with each other. We cannot disclose their reports without their consent. STI screening is important. And if we are offering the patient IVF, we have to address the risk factors and NHS funding. If the patient's BMI is more than 30, she's a smoker, she has any child before, then in that case, NHS will not fund the IVF cycle. And regarding the funding, it needs to be discussed with a GP. GP can discuss with the clinical commissioning groups. Also, we have to inform the patient about the risks of fertility treatment, like OHSS, ovarian hyperstimulation syndrome, and multiple pregnancy. Another module is the oncology module. So here, again, the triad and referral pathways are important. That is the 2 weeks pathway. So if the patient has been diagnosed with cancer and after that she has been referred from a GP, so within 2 weeks of diagnosis, like patient needs to be seen and treated by the experts. Also, support in such patients is very important. We need to provide them with the emotional support and give them the support group numbers. Coming to the urogyne module, again referral and stepwise treatment is important. I'll just give you a simple example, like if the patient has stress urinary incontinence. So first is the conservative management, lifestyle modification, weight reduction, treatment of any chronic cough or constipation, and pelvic floor muscle exercise under supervision of physiotherapist. So under supervision of physiotherapist, very important patient safety point, for a duration of 3 months. If this doesn't work, then we will be referring the patient to experts, involve your consultant. There is going to be an MDT meeting, and then we will be offering the surgical treatment. So like these are the simple patient safety points which I have tried to cover in all the modules. So as I told in my last audio, you will be able to remember it only when you're practicing cases with your study partner. Talking and speaking and communicating is very important if you're going for this exam, because in the exam you have to speak for 3 hours. So it's not easy. If you're not practicing, if you're not talking, then it's going to be very difficult to speak in the exam. So get a study partner, honest one, practice the cases, and keep hustling. Okay, so that's all for now. Thanks for listening. I hope this is helpful. Take care and bye-bye.